So you all should be able to see those grades as they update, as I get all of those assignments graded. And don't forget about the quizzes next week. There'll be a quiz on, let's see, Tuesday, Wednesday, and Thursday. And then what I've done is the day after the quiz is due, for a 24-hour period of time, I'll leave the quiz open. So then you all can go back in, look at your answers and reference them, since I won't necessarily be around. I will for at least the first part of the week, but I'm going to be in a lot of different meetings. And so I may not be readily available. So as is the nature with these spring breaks, they try to do committee meetings and all that. So that's what's going on there. Let's see. So before we get going, are there any questions? All right. It looks like we're caught up on chat. All right. So we were able to make it through the cardiovascular pharmacology yesterday. And today what we're going to do is we're going to focus on, and I kind of gave you all a heads up, but we're going to focus on analgesics, sedatives, and then we'll talk about the neuromuscular blocking agents. And I may just spend a few minutes talking about a procedure where these agents are sometimes used, called RSI, that some EMS systems utilize here in the state of New Mexico. Or even if you work for a system that doesn't utilize that tool, you still need to be aware of it and kind of what goes on and know a little bit about the medications used. All right. So let me go ahead and share with you all, and we'll just roll right into lecture for today. All right, there we go. Okay. We talked a little bit about the NSAIDs yesterday, the non-steroidal anti-inflammatory drugs like ibuprofen, ketorolac, aspirin, acetylsalicylic acid falls into that category. And we talked about acetaminophen as well. So I'm going to take a deeper dive into opioids and opiates today. And let's just talk about the basic mechanism of action of these agents. And as I said yesterday, an opiate, something is an opiate if it is a direct derivative of opium that comes from certain kinds of poppy plants, from the bulbs. There's a bulb prior to the flower blooming. You get these bulbs that build up, and the bulbs kind of crack, and when they crack, they release a thick viscous liquid, which is where the opium comes from. And then of course the bulb opens up and the flower comes out. Something is a direct derivative of that opium. We call it an opiate, and that primarily includes morphine and codeine. Seriously. Interesting. Includes morphine and codeine. Something else is what we call an opioid, and that is essentially if you have to do any chemical modification. For example, we can take morphine and we can add acetyl groups to it and create something called diacetylmorphine, which is also known as heroin. So heroin is in fact an opioid because it is a chemical modification. And then there are some fully synthetic opioids that have an entirely different chemical structure to them than the opiate derivatives. And these are sometimes referred to as open ring structured drugs, such as fentanyl, sufentanil, carfentanil, remifentanil. So all of the fentanyl derivatives tend to fall into that. And their chemical structure is markedly different from the more opiate-like drugs. And so the fentanyls tend to be incredibly potent and have high efficacy. And so the dose for these particular agents tends to be much lower. Tends to be in micrograms as opposed to milligrams. So these are roughly 10 to 100 to sometimes more than 100 times more potent than their more opiate-related brethren. But be that as it may, the primary mechanism of action for all of these agents is, or rather surrounds, the concept of an opioid receptor. So we have these opioid receptors in our body. And let me just ask a question. Why do you think it is necessary for us to have an opioid receptor in our body? What's that all about?
Because your body has indigenous opioid like, I guess.
Yep, absolutely. You're absolutely right. Our body creates chemicals, substances that are opioid-like. Yeah, they are endogenous opioid-like substances. And so there's some biological reason that we have these opioid receptors. And we'll talk about the biological reason. And the biological reason really kind of surrounds modulating pain, anxiety, and other related phenomena. And one area where this might be helpful is when it comes to physical activity. Engaging in physical activity is inherently painful. And as many of you know, has anyone or does anyone remember like starting a new workout routine or starting to run or starting to do something for the first time? And what do you notice after starting a new workout routine? Most people would notice that it sucks. It's painful. You're incredibly sore afterwards. And you just don't like it that much. And so there are certain moments in our lives where we would like to shut some of that pain and discomfort down. And that's what this Endo opioid system seems to be about. Seems to be about modulating pain and discomfort during times of stress or during times where we need to put a demand on the body and we can't be bothered with having all this discomfort getting in the way, right? So think about like if you're running, right? Long distance running. Well, human beings, we didn't evolve to go out and run 5 miles, but we evolved to chase down animals and to run from animals. And you don't need to be bothered having a lot of pain when you're on the run trying to survive, right? And so that's kind of where this system becomes helpful. And when we talk about this system, there are 3 primary opioid receptors. There are actually other receptors that opioids can agonize, but these are the primary receptors, and these include the mu. So that's the Greek mu, a little U-looking thing. It's a lowercase mu. There are mu receptors, kappa receptors, and there are delta receptors. So these are the 3 primary opioid receptors: the mu, the kappa, and the delta. And these receptors are primarily found in the spinal cord and in the brain. And when these receptors are agonized by these endogenous and external substances, you have a variety of effects. When it comes to the endogenous chemicals that are produced in the body, there are broad classes of these, and they, broadly speaking or roughly speaking, have a higher affinity for one of these three opioid receptors. For example, the endorphins have a high affinity for the mu receptors in the body, whereas dynorphins have a high affinity for kappa receptors, and enkephalins have a high affinity for the delta receptors. So you have endorphins, dynorphins, and enkephalins. And now you know where those terms come from when people talk about endorphins, right? I've got endorphins. Well, endorphins are chemicals produced by your body to agonize mu receptors, right? So they're part of our endo-opioid system. So let's talk about what each of these receptors, and there are several subtypes of receptors, but we're just going to keep it simple and stick with the major types, the mu, the kappa, and the delta. Let's talk about what these receptors do. So first of all, these receptors are G protein coupled. So they are metabotropic receptors, which means when they are agonized, they are coupled to G proteins, and those G proteins get activated and they cause downstream intracellular effects. Typically secondary messenger molecules are produced. So the physiology of these is fairly complex. So if you agonize mu receptors, okay, these are responsible for causing respiratory depression, so decreased rate and depth of respirations. These can cause euphoria. These can cause sedation, urinary retention. Urinary retention is sometimes a problem with people who take lots of opioids, and sometimes they even need catheters placed due to the urinary retention, and that is due to mu receptor agonism. Decreased GI motility. So another common side effect of opioid use is constipation, because you have a reduction in peristalsis in your gut. And so the transit time can increase, and that means more water gets pulled out of the fecal matter. It hardens up and it can get caught. So constipation and bowel obstructions sometimes can occur in these patients. In addition to this, sometimes opioids can be used to slow the gut down if somebody's having a problem with diarrhea or too much having bowel movements too frequently. And in fact, there are special suppositories that are sometimes given, and they're referred to as B and O suppositories, and that stands for Belladonna, an opioid. So it is a suppository that contains opioids, and it contains extract from the Belladonna. Does anyone know what the Belladonna plant, what that has in it?
No.
No. Does it know what Belladonna means?
Beautiful. Beautiful lady.
Beautiful lady. Yeah, beautiful lady. Yep. And so where this actually comes from is back in the day, people would take extract of the Belladonna plant and put it in their eyes, and it would cause their pupils to dilate. And that was apparently seen as an attractive thing. And so it was not uncommon for prostitutes, for example, to use this to make them more appealing. So apparently big eyes is not just something that is an important part of certain cartoons. It has apparently some deep cultural meaning to it. And we now know that the Belladonna plant contains lots of alkaloids that are anticholinergic, right? So they are atropine-like, right? Things like hyoscyamine and scopolamine. And so a BNO suppositor, the Belladonna, going to cause anticholinergic effects in your gut. So what's that going to do? It's going to dry it out and slow it down. And then the opioid will further slow it down. So you can see why that might be a good mixture if you have a patient where you're trying to get control of diarrhea. Unfortunately, a lot of our patients that are taking lots of opioids and opiates tend to have the opposite problem. They tend to have decreased GI motility and problems with constipation. Pruritus. What is pruritus?
That's just itching, right?
Yeah, they get itchy. Yeah, they get itchy all over. They can. So those are all associated with the mu receptors. And I should also say that there is, of course, a decrease in the perception of pain when mu receptors are agonized as well. Now, when it comes to kappa receptors, we get some additional effects. We get meiosis. And what's meiosis?
Pupil constriction.
Yep. Bilateral constricted pupils, like classically seen with people that take opioids or that are given opioids. This can also cause dysphoria and agitation. So sometimes a side effect of a side effect of an opioid, you give it to somebody and they may actually, they may tell you they don't feel good. They get upset, anxious, agitated, even combative in some cases. And that seems to be due to that opioid acting upon the kappa receptors. It can also cause sedation, although we do not see the respiratory depression that you see with mu receptor activation. And then there is actually a drug that comes from a plant called Salvia divinorum. And this drug, typically smoked, has high affinity for kappa receptors. In fact, it activates almost exclusively the kappa receptors, and that can cause a temporary psychedelic-like state. These patients can become dissociated, incredibly anxious, and hallucinate. They can have lots of dysphoria and agitation. And that's how salvia works, is it is a very potent kappa receptor agonist. And then finally we have alpha receptors. When these are activated, particularly in the spine, they signal analgesia. And so sometimes when we place an epidural, say, right, we place a catheter into the epidural space, we will sometimes inject an opioid into the epidural space around the spine, around the spinal cord. And that's because that opioid, typically fentanyl, can attach to delta receptors and other receptors in the spine and can cause analgesia. And that's nice because then you're not giving that systemically and causing lots of sedation, right? So you can be very surgical with the analgesia that you're providing. This can cause a decrease in anxiety and can have some antidepressant effects. All right, so those are three major receptors for opioids. They're endogenous substances that bind to them and the effects that we see. So now what I want to do is I just want to talk about some specific examples of common opioids that we run into. Morphine and fentanyl tend to be the two most common. And what I find is that there is a fairly substantial preference to fentanyl. Lots of people have a preference to fentanyl. And what I'm going to do here is I want to compare and contrast morphine and fentanyl and hopefully show you that these agents have both pros and cons associated with them. And you may want to choose one over the other depending on the situation. So let's talk about morphine first. So morphine, typical dose, 2 milligrams up to 10 milligrams. Typically people will do like 2 milligrams and then 4 milligrams. So you can titrate your boluses of morphine. Most guidelines say a maximum of 10 milligrams, but that varies. And it can be given via the IV route, the IM route, the IO route, and there are also oral formulations of morphine, PO, a kind of liquid. It's called liquid morphine that is out there as well, but we typically are giving it IV, IO, and possibly IM. So what are some of the unique properties of morphine? Well, morphine is associated with histamine release. It causes a release of histamine. And that histamine causes dilation. And so that will be associated with some preload reduction, which can reduce the blood pressure. And that may be helpful in some instances. It may be helpful in somebody having ischemic chest pain, for example, and you're reducing the preload a little bit, and you're taking some of the workload off the heart. And that may further help with their chest pain. Of course, you need to be careful that you don't cause hypotension, which is a side effect of morphine. Morphine can also cause a fair amount of nausea. And so often opioids like morphine are given with antiemetics for that purpose. And in addition to that, some antiemetics can also potentiate the action of the opioid. And so there are good reasons to give these together to the same patient. Another interesting thing about morphine is that it has a longer duration of action compared to fentanyl, substantially longer, up to hours in some cases. And of course, respiratory depression and loss of airway protection, hypoventilation, et cetera, are all problems associated with the opioids that we need to be on the lookout for. Now, fentanyl, on the other hand, is incredibly potent. You're looking at your classic doses of 25 to 50 micrograms that can be given IV or IO typically. And so you can see that it is essentially 50 micrograms of fentanyl is roughly equivalent to 5 milligrams of morphine, right? And so you can see that it is orders of magnitude more potent. Some interesting things about fentanyl is it is not associated with histamine release, which means what? Well, it means that it tends not to impact the blood pressure as much as something like morphine. So fentanyl may be an agent that you would want to use in somebody where blood pressure is a concern, right? You want to give them analgesia, but you are concerned about their blood pressure. Fentanyl may be a very good option. However, fentanyl has a very short duration of action, typically less than about an hour in many cases. So repeated dosing of fentanyl may be needed, particularly if you're looking at a prolonged transport and care situation. And then fentanyl does have some unique things associated with it. There is something called rigid chest syndrome or stone chest syndrome. And this tends to occur when fentanyl is given rapidly. So we never give any of our opioids, but there's always going to be a slow IV push, typically over a couple of minutes. That includes morphine as well, because if you give morphine too rapidly, you can cause lots of nausea, you can drop blood pressure. Whereas if you give fentanyl very rapidly, particularly at larger doses, you can cause that rigid chest syndrome where their chest wall muscle seize up, and it can be very difficult for them to breathe and can even cause essential respiratory failure in these patients. It's fairly rare, but I want you all to be aware of it. And then, of course, it's an opioid and it can cause respiratory depression as well. So here's the thing. The unique property of these agents means that we can use them in different situations, or they will shine in different situations. For example, morphine is good in situations where you want something to have a prolonged duration of action. For example, morphine is generally to be better in burn patients. Somebody who's been burned, right? This is not a pain that is going to go away anytime soon. So giving large doses of something that has longer duration of action is going to be a better plan, right? Whereas if blood pressure is a concern, then fentanyl may be the better agent to go with. So you can see that the properties of these agents may allow them to shine, so to speak, in certain situations. So don't necessarily discount morphine because everybody's using fentanyl. Morphine does definitely have a place, and its long duration of action is actually really nice, even in trauma patients as well. Right? If you have a trauma patient, but you stabilize their blood pressure is not a big issue, right? Giving morphine be very helpful because it's going to last a long time. And unfortunately, for the patient, sometimes the only time a patient gets medicated for pain may be in the back of an ambulance, right? So you take that patient to emergency room, it's busy in the ER, there's lots going on, they fall through the cracks, they don't ever get adequate pain medication. And so if you can give them something that has a long duration of action, right, to see them through at least part of their care while they're in the emergency room, right, that's really good thinking, and it's really looking out for the patient. Whereas if you give fentanyl, right, that fentanyl is going to have a fairly short duration of action, and that may wear off fairly quickly in the emergency room. And if that patient falls through the cracks, they may be under-medicated or unmedicated. And that, of course, can lead to lots of psychological and physical distress for that patient. So another thing to think about there. So that's morphine and fentanyl. And those are the two major opioids that we tend to administer as providers. However, I do want to talk about some other agents that are out there that are given and prescribed, just so you're aware of them. So let's just talk about some commonly prescribed and used agents. Before I do that, however, I do want to talk a little bit about fentanyl and its derivatives, sufentanil, carfentanil, remifentanil, etc. There has been a lot of press lately about the safety of these agents. And what I mean by that is people being exposed potentially to these agents in the pre-hospital environment. Like if you go into, say, a house or a drug lab or something like that, you see some substance or powder on a table or a book or something like that. There have been lots of reports of people having problems, and they're talking about people inhaling it or absorbing it through their skin and having an overdose on scene. A very popular video right now of a police officer who's kind of looking at some powdery substance, and I think his FTO came by and said, hey, you know, that stuff might kill you. And then immediately he falls to the ground and kind of has this weird anxiety like issue. And I want to address that real quickly and say that a lot of this stuff is highly overstated. It is very difficult to absorb these substances through your skin or even inhaling them in any substantial amount to cause an overdose-like situation. In fact, to get these drugs to absorb into your skin, we have to heavily modify them. And then we have to put them in a lipid solution and then put that solution on a patch. And that's where something like a fentanyl patch comes into play. Right? So we have to heavily modify these molecules and put them in a lipid transporter, essentially, to get them to dissolve and to cross your skin. Your skin is a very robust barrier to even inhale them. So the risk of overdose in contact with these agents out in the streets is very overblown. And a lot of it is just kind of psychosomatic, unfortunately. And let me ask you a question. What does somebody who is overdosed on an opioid look like? What do they look like to you? You guys, you all have probably taken care of an overdose. So what do they look like?
Unconscious.
Yeah, they're incredibly, they have a profound central nervous system depression. They're breathing very slowly, maybe not at all, right? They're not breathing rapidly. They're not having anxiety. They're not throwing themselves onto the ground, right? Those are not characteristic behaviors of somebody who is experiencing what we refer to as an opioid toxidrome, right? An opioid toxidrome is someone who is not breathing, is not really responding. They're incredibly lethargic, right? So you also want to keep that in mind. But with that said, the overdose of fentanyl and its various derivatives is a very common problem. And a lot of the street drugs out there are adulterated or contaminated with these derivatives. So somebody may be thinking they're storing some heroin, and that heroin just happens to have some fentanyl or some carfentanil in it, and which is orders of magnitude more potent than the heroin. The person using it doesn't know, and now they get a big dose of a fentanyl derivative and they're down and out, right? And so we do run into a lot of this stuff. In addition to this, there are lots of people who, unfortunately, due to the medical system and the pharmaceutical system, have become addicted to prescription opioids. And now that's being rolled back substantially, and they can't get their pain medicines or their opioids, and they are now turning to street drugs to have access to opioids. And a lot of this really started back in the early and mid 1990s, when there were lots of potent, long-acting opioids, things like MS-Contin, for example, right? Oxycontin, things like that. These fairly potent, sustained release opioids, and they were pushed very heavily. As in fact, I will admit this, I was taught as a nursing student, because I went to nursing school in the late 90s, and we were taught, nurse students, to help people. And we thought this, we were doing good, but we were told that if somebody was really having pain, they were actually having pain, they could not become addicted. So tolerance, dependence, and addiction are not problems when somebody's in pain. Obviously, we know that's not the case, but that's the narrative that was being told then. And so there were lots of people who were put on these meds, and a lot of people thought, hey, I'm being prescribed this, I have pain, this is completely legitimate, this is not a problem, I'm not going to have any issues. And now, 20, 30 years later, they're dependent and addicted to opioids. And now that the government's like, well, opioids is a problem and we need to stop all this prescription and regulate it even more. And now people are turning to street drugs, right? Turning to street drugs. So yeah, it's a real interesting problem that we're dealing with right now. So I just wanted to kind of bring that up, to just let you know that, and most of you probably know that this is a problem, right? Opioid abuse, overdose, and all of the issues surrounding it, the social issues surrounding it, are just a huge problem right now throughout our society, and we have to deal with it quite frequently, unfortunately. Okay, so let's move on and talk about some other specific substances. So occasionally you might run into a substance called parodine, also known as Demerol. It's not as commonly used as it once was, but it's still out there. What I want you to know about parodine is that there are metabolites. When parodine gets metabolized, there's a metabolite of parodine called normeparidine. And normeparidine actually decreases the seizure threshold in the brain. And so this can increase the risk of somebody having a seizure. So that kind of special thing you want to think about. Hydromorphone is another common agent. It's used quite a bit. In fact, you probably will give a fair amount of hydromorphone when you do your ER rotations, because it's commonly used in the emergency rooms. And hydromorphone, or Dilaudid, kind of splits the difference between morphine and fentanyl. It has many of the same, it's a little longer acting than fentanyl, but it's more potent than morphine. So hydromorphone, you're typically giving 0.5 to maybe 1 to maybe 2 milligram doses, versus 2 to 10 milligrams of morphine, or 25 to 50 micrograms of fentanyl. So hydromorphone is a little more potent than morphine, but not as potent as fentanyl. Some other agents I think I mentioned earlier in the week, things like hydrocodone are very common prescribed medications, and oftentimes hydrocodone is mixed with Tylenol. And so when you see that, you might see like 500, for example, and that means that this is a mixture, 5 milligrams of hydrocodone, 500 milligrams of acetaminophen. And sometimes hydrocodone and oxycodone as well can be mixed with agents like ibuprofen, right? Like Vicuprofen is a mixture of hydrocodone and ibuprofen. And then there's another drug out there called tramadol, also known as Ultram. It's not as common now, but Ultram is a kind of unique opioid. It has some of the same problems that we see with meperidine, as far as like the risk for seizures. There's a dysrhythmia risk because it can impact ion channels in your heart. So you got to be careful there. And for a long time, tramadol was very easy to get. It was actually not highly scheduled and regulated, and so people were able to get a hold of it fairly easily. And so you run into issues with that as well. In all cases, though, just remember that naloxone or Narcan can reverse the overdose. However, what are your primary concerns when taking care of someone who may have overdosed on an opioid? Like, what's your primary primary concern.
Hypoxia?
Yeah,
Okay, and
respiratory.
like, what's your say that again?
Respiratory.
Yeah. So our major concern is going to be really revolving around their respiratory status and airway management, right? If somebody is not breathing and they have an airway full of vomit, it doesn't matter if we give them naloxone or not, right? The immediate action, so to speak, is to suction them out, begin bag mask ventilation, right? And then at the same time, you can arrange for that patient to receive appropriate doses of naloxone. So there's a really interesting movie. It's actually quite dated, but it was made in the 90s. It was called Bring Out the Dead. It was supposedly about New York EMS providers. And there's a scene where a guy's overdosed in a club on heroin, and nobody's doing anything, and they give this guy, they mainline some naloxone, and they wait, and he wakes up. That's completely inappropriate, because you want to open the airway, suction if needed, begin bag mask ventilation, right? Stabilize that patient's respiratory and airway status, and then look at getting naloxone on board. But let's talk about naloxone. How do you all dose it? How do you give it? How do you dose it?
Two milligrams, 1 milligram in each nair, generally.
Okay, you can do that. But now paramedics, and we have the ability to place IVs and IOs.
So
And remember, so the problem with giving large doses of naloxone, well, what is a potential problem with giving somebody a large dose of naloxone?
Waking them up.
Quickly
They come
become
out
responsive and combative.
Yeah, so you reverse the overdose. Sudden, complete reversal of the overdose is not what we want, right? What we want is a patient who's awake enough to be breathing adequately and to be protecting their airway. That's really what we want. They don't necessarily have to be completely awake and anxious and withdrawing. And giving large doses of naloxone and suddenly reversing overdose can cause nausea and vomiting in some patients, right? So you can actually inadvertently cause aspiration, loss of airway protection, right? And in some cases, you can actually, if you're bagging somebody or you're trying to manage their airway, a very large dose of naloxone, and you reverse that overdose, there can be rapid pressure changes that happen in the lungs, and that can actually cause a sudden onset pulmonary edema. We call this flash pulmonary edema, where the lungs fill up with fluid. It's not super common, but it's something that we can do. So what I tend to recommend is going with a much more measured approach to giving naloxone, right? And I think somebody mentioned 0.4 milligrams, slow IVIO. I think it's a reasonable way to go. I've gone lower than that, where I'll give 0.1 milligrams every minute or so, and I will just titrate the naloxone to the patient's response, right? Because I don't want them withdrawing. I don't want all of that. I want them to be uncomfortable, but I want them to be awake enough and breathing and protecting their airway adequately. So being a little more judicious and a little more cautious with how we use naloxone may actually result in better outcomes and more comfortable patients. So any questions over the opioids?
Chris, I have a quick thing going on. I got a family emergency. I gotta head to my dad's house real quick. They're saying he's possibly having a stroke.
Okay, no worries. All right.
Chris, with the naloxone and the reactions, a lot of times, at least recently for me, we've had to give multiple doses, like maybe
Yes.
the strength of the drugs and stuff like that. So that's just the fentanyl or?
Yeah, and who knows what the adulterants are. And oftentimes, because naloxone has a fairly short its half-life is fairly short, the duration of action of naloxone is often shorter than the duration of action of the opioid. And so it is fairly common that we need to do repeat dosing of naloxone, because its duration of action may in fact be shorter than whatever the opioid is. So yeah, that's a fairly common thing, and that's not a problem. And the cool thing is if, let's say it's not an opioid overdose, is naloxone particularly harmful if given? If you give it to somebody who has not overdosed on opioid, what do you all think?
Not really.
No, it's not. It's actually, naloxone has actually been referred to as the perfect antidote. And there are very few like actual antidotes, but it is almost a perfect antidote because it is very specific. It has almost no side effects. And if you give it for the problem and the problem doesn't actually exist, generally there will be no issues. So it is actually a great agent. And so you shouldn't be afraid of using it. Just know that if you are using it, there are ways you can use it to kind of help produce a better outcome for all parties involved. All right. There are also some other opioids out there like methadone. And methadone is commonly used. It's a very long acting. It has a very long duration of action. And so it's commonly given to people who may be dependent or addicted to opioids. And so to try to get them off of, say the heroin or the fentanyl that they're using, we'll give them methadone, and it has a very long duration of action, so they don't withdraw, and then they can hopefully come off of having to inject themselves with fentanyl, heroin, who knows what else. So methadone is very commonly used for that reason. There are also mixtures of drugs like Suboxone, for example, which is a mixture of an opioid and an opioid antagonist like naloxone. And so what happens with Suboxone is it's hard to overdose on, because the more of it you take, the more of the antagonist you have, because it's mixed in there. It's a mixed agonist antagonist. And so there's a ceiling of effects, and people are far less likely to overdose. So you may see people on Suboxone and methadone that are, attempting to deal with an underlying opioid addiction. So I just kind of wanted to throw those out as well. All right.
Chris, I have a
Well,
question.
moving on. Yeah, what you got?
So in the hospital, I've seen and given a couple of Narcan drips. I was wondering if that's something we could do in the field.
Yeah, you could do that in the field if you wanted. It just would be the logistics of it would be tough because you having to mix a drip, right? You have to mix a drip, and then you have to figure out a flow rate and to titrate it. It's doable, but typically you're just going to find people are going to give boluses of it and then redose. But certainly, yeah, you know, if it's somebody's over, like, you know, let's say it's like a massive methadone overdose, for example. I mean, you're going to be dealing with that for a long time. So it would make sense that you would want to mix a naloxone drip and then titrate it to the response, because of the prolonged duration of action of that methadone. So it's a possibility. Absolutely.
Cool. Thank you.
Yeah, no problem. All right. Well, what I'm going to do is I'm going to move on to the next class of drugs. These are not analgesics. All right. And this is very important. These are sedatives. And a sedative may make somebody look like they're not in pain. But let's be very clear. You can still be sedated and in a lot of pain, and your body can still be physiologically reacting to that pain, right? So do not think that just because you've given a sedative that you have dealt with somebody's pain, all right? And so I'm going to talk about some of the common categories of some of these sedative agents. And the most common category or class are what we call the benzodiazepines. And the benzodiazepines interact with what are called GABA receptors. GABA receptors. And GABA, inside of the brain, in the central nervous system, there are two major neurotransmitter systems. The primary excitatory neurotransmitter in the central nervous system is glutamate. And the primary inhibitory neurotransmitter in the central nervous system inside of the brain is gamma aminobutyric acid, also known as GABA. So what these benzodiazepines do is they indirectly interact with the receptor for GABA in the central nervous system. So the way that this works is, here's the cell membrane of the neuron, here's the GABA receptor, and here is the active site of the receptor. And the GABA molecule, it's a neurotransmitter, attaches to this site and agonizes the receptor, activates the receptor, and the receptor is a chloride channel, so it's an ionotropic receptor. And when it opens up, chloride ions enter the neuron. And what that does is that adds more negative charge into the neuron. And the neuron already has a lot of negative charge compared to the outside, right? It's polarized, but more chloride ions means that the neuron becomes hyper polarized, and it will be harder for that neuron to depolarize. And so in essence, what you've done is you have suppressed the neuron activity. Now, what benzodiazepines do is benzodiazepines bind to the GABA receptor, but they bind at a different site. So maybe the benzodiazepine binds, I'll draw it in blue here, it binds over here on the receptor. It does not bind to the active site. So the benzodiazepine cannot directly activate the receptor, agonize it. But what it does is when the benzodiazepine binds to the receptor, it makes the receptor more sensitive to GABA. The receptor will stay open longer and allow more chloride. So it makes the receptor more sensitive to GABA, right? And when you have that kind of mechanism where it is not directly interacting with the active site, we call that an allosteric mechanism or an allosteric action. Some drugs are that way. They don't directly interact in the active site of the receptor. All right. So these hyperpolarized neurons are suppressed and they do not depolarize, or it's much more difficult to depolarize them. So why are these agents used? Well, these are used for anxiety, for agitation, for sympathomimetic overdose. So someone is overdosed on a sympathomimetic agent, something like cocaine or methamphetamines, right? Can help control the anxiety and the behavior associated with that. These are anti-seizure medications, and some of these agents at high enough doses can act as what are called induction agents. And an induction agent is something that we use in airway management typically, and in the surgical setting, to cause a rapid onset of loss of consciousness. And some of these benzodiazepines can act as induction agents, specifically something called Versed or midazolam, and I'll talk about that here in a little bit. All right, so that's the main mechanism of action of benzodiazepines. And so benzodiazepines roughly fall into two major groups: short-acting and long-acting or longer-acting. Your short-acting, the major short-acting benzodiazepine is something called midazolam, or Versed is a trade name. The longer-acting common examples include diazepam, also known as Valium, and lorazepam, also known as Ativan. All right. These are also commonly prescribed, okay, outside the hospital, and these are commonly used as anti-anxiety or anxiolytic medications and sleeping aids. For example, a common one is something called alprazolam or Xanax, which is an oral prescribed benzodiazepine. And I also want to be very clear, benzodiazepine withdrawal is one of the two withdrawal syndromes that can be acutely life-threatening. Does anyone know what the other major withdrawal is that can be life-threatening?
Alcohol.
Yeah. Alcohol and benzodiazepine withdrawal syndromes can be acutely life-threatening. And it makes sense, right? Because if you're withdrawing from benzodiazepines, this benzodiazepine goes away, right? And now the receptors are not able to act appropriately when GABA is present, and the neurons are not hyperpolarized like they should be or like they've gotten used to. And now you have hyperexcitable neurons, and these patients can have seizures and they can have hallucinations and severe anxiety. Same thing that we see with ethanol withdrawal, because alcohol also interacts with GABA receptors to cause central nervous system depression. So when the alcohol goes away, you have a very similar process occurring. And when that occurs in alcohol withdrawal, we call that delirium tremens, right? DT or delirium tremens. And it's a similar thing: seizures, anxiety, hallucinations. So what are we worried about with benzodiazepine overdose? Well, it can cause respiratory depression. Is there an agent that can reverse benzodiazepines? Yes, there actually is. It's hard to get a hold of. It's not commonly used, but it's something called flumazenil or romazicon. It can at least partially reverse some of the effects of benzodiazepine. But typically, benzodiazepines, if you just manage airway, appropriately position the patient, they tend to do okay. Whereas like an opioid overdose, they often will require reversal because they're often not able to protect their airway, and they're often markedly hypoventilating. So those are the benzodiazepines. Some other side effects, if you give benzodiazepines too quickly, specifically these guys here, because these are the ones we tend to use in a pre-hospital context, midazolam, diazepam, or lorazepam, you can cause hypotension. Occasionally, midazolam is also used nasally. Does anyone know what the context for intranasal midazolam is?
Seizures.
Be for someone you can't get an IV on.
Yep. So maybe you can't get an IV or an IO and they're actively seizing. You could give them intranasal midazolam, and people with seizure disorders may carry intranasal midazolam, and so it's not uncommon for you to get on scene and the friends or family told you that, hey, we've given the patient their medicine, we've given them 10 milligrams of midazolam IN intranasal. Yeah. Okay, excellent. So benzodiazepines are primary agents that we use. There is another category of agents. These are referred to as the barbiturates. And it's already 9:30, so guess what? Let's go ahead and take our first break. Any questions before we take our first break? Excellent. So I've got 9:30. Yes, I'm sorry.
I believe I remember there's like multiple benzos you can give IN. It's not just midazolam, right?
Yeah, you can give I think you can give diazepam or Valium intranasal. I don't know about lorazepam. Typically, lorazepam is a fair. Well, both diazepam and lorazepam are pretty long-acting agents. So it just makes sense that midazolam would be probably the better agent because it's fairly short-acting, fairly short duration of action.
Okay.
You can even give some of these rectally as well, like diazepam. In fact, they actually make rectal suppositories of diazepam. So yeah, there are other routes of administration for some of these agents. Absolutely. Okay. Well, I've got it's at 9:34. So how about I just see you all back at 9:45. All right, welcome back to the second half of lecture, everybody. So we'll pick up and we'll probably go a little bit quicker just because some of these we're going to cover more topically, and these aren't agents that we could administer. So we just kind of have to know a little about them and a little about what they're used for and some of the issues associated with them. So the next category of sedatives are what we call the barbiturates. And these barbiturates have actually been around for many, many decades. And these are some of the original anti-seizure meds that were developed. They have a very similar mechanism as the benzodiazepines, but can directly agonize GABA receptors at large doses. And let me see if I can share this with you all. There we go. So the barbiturates are very similar to the benzodiazepines, but at larger doses, they can directly agonize GABA receptors, whereas benzodiazepines are primarily allosteric. Unfortunately, the barbiturates have multiple drug, food, and enzyme interactions. So they are very problematic when it comes to adverse effects due to other drug metabolism, due to inhibition and excitation of other enzymes and enzyme systems, and multiple drug and food effects. So common examples of benzodiazepines include phenobarbital, also known as luminol, pentobarbital, and something referred to as sodium thiopental, or STP. Sodium thiopental, like agents, is used exclusively as an induction agent. So it's a very rapid acting, short duration of action agent, can be given, not given so much in the United States anymore, but it is actually on the World Health Organization, the WHO, list of essential medications to have around the world. And so it is commonly used as an induction agent outside of the United States. It's very rapid acting, like I said, and short duration of action, but it does tend to impact the blood pressure very heavily. It can cause hypotension. Now, phenobarbital tends to be used a little more commonly, and phenobarbital can be used as a second-line seizure medication. So let's say that you have tried benzodiazepines, which tend to be our frontline medications for managing acute seizures. And then that is not working. You might look at adding a benzodiazepine like phenobarbital in. And very rarely, there is something called a barbiturate coma. And this is sometimes where somebody is placed into a comatose state using medication like barbiturates. If they have like major head injury or something, and we decrease the metabolic stress or demands on their body, we can use a barbiturate like phenobarbital to put them into a very deep coma. There are other agents that can do this as well. So this is not as commonly employed as it was in the past. So the barbiturates are kind of falling largely out of favor in the United States, but you might see people on something like a phenobarbital, particularly if they have difficult to manage seizures. But again, lots of side effects. The barbiturates can cause, just lots of interactions and side effects. We'll just leave it at that. So let's now talk about some other induction agents and sedatives. So these are going to be agents that do cause sedation, but they're primarily used to induce, to cause rapid onset loss of consciousness for airway management and surgical procedures like reducing a joint for joint dislocations or fractures, or even the initial stages of surgery. And I'll go through some important ones that you need to know about. Probably one of the most commonly used agents is something called propofol, also known as Diprivan, propofol or Diprivan. Some people call this the vernacular name, quote unquote, milk of amnesia. It works through interacting with GABA receptors, as many of these agents do. And propofol has a very rapid onset in an incredibly short duration of action. So you give it, you get the effects. As soon as you quit giving it, within a couple of minutes, it begins off. Hypertension is a risk, though. So a reduction in blood pressure is very common with propofol. And propofol can also be used as a second-line anti-seizure agent. Oftentimes, propofol is used as a continuous infusion. So you can give it as a bolus, you give it as a rapid bolus to cause onset of, or the induction, the onset of a loss of consciousness. But you can also use it as a continuous drip for ongoing stage, typically after somebody has been intubated. So maybe they're going to be intubated for a period of time, and they're going to be transported, or they're going to be in an ICU. You can use a propofol drip and then titrate the dose to the amount of sedation. And then the cool thing about propofol is, as soon as you shut the drip off, within a couple minutes, if the patient's neurological status is intact, they will wake up very rapidly. So it's a very good agent in that respect. It can be associated with lipid metabolism problems because it is highly lipophilic. And it's essentially, it is a lipid-based solution that propofol comes in, which makes sense. It rapidly penetrates into lipid-filled spaces in your body, like your brain. There are some, in addition to the risk for hypotension, there's something called PRIS, and that stands for propofol-related infusion syndrome. And this tends to be people that are on propofol for an extended period of times, greater than 24, 48 hours. And you can get a syndrome where they have an unexplained metabolic acidosis that develops, their pH gets low, they develop a kidney injury and an acute renal failure, rhabdomyolysis, hyperkalemia, cardiovascular collapse, and dysrhythmias. And this is all collectively referred to as propofol-related infusion syndrome. So propofol has some great properties associated with it, but it also has some other more problematic issues associated with it. The next agent is something called etomidate or amidate. And etomidate, like propofol, probably has a GABA-related mechanism to its action. Like propofol, is a very rapid onset and a very short duration of action agent, a little longer duration of action than propofol. I used this quite a bit when I was an active flight nurse during RSI procedures, and you can reliably get about 100 seconds of unconsciousness for every 0.1 milligrams per kilogram that you would give, and we would generally give about 0.3 milligrams per kilogram. So you'd get about 300 seconds of unconsciousness, or about 5 to 7 minutes of unconsciousness with a dose of etomidate, which was about the same period of time that a certain paralytic that is commonly used called succinylcholine would last. Now, unlike propofol, etomidate has a low risk of hypotension. It does not cause the hypotension that we see with propofol, although people can have some muscle jerking. We call that myoclonic jerking. So it kind of looks like seizure activity, even though it's not. And a single dose of etomidate can suppress the adrenal gland for up to 24 hours after giving it. This may be harmful or problematic in people who have underlying adrenal issues, like septic shock patients, children, and patients with underlying adrenal suppression, right? Etomidate may not be a good agent for them. And etomidate cannot be given as a continuous infusion. So typically, it's a one-time bolus, and that's that. So unlike propofol, you cannot use it as an continuous infusion. All right. The next agent is very commonly used in ICUs as well, and this is called dexmedetomidine or Sedatives. And its mechanism of action is completely different. It actually is not a GABA-based mechanism of action, but rather it blocks alpha-2 receptors. So you all are familiar with alpha-1 receptors, but alpha-2 receptors are primarily located in the central nervous system, and blocking these receptors results in depression of certain neurons and neuron systems, and this can cause sedation. And so that's where this strip is used. Unlike some of the other agents, this can actually cause a transient elevation in blood pressure and tachycardia. Like the other agents, very rapid onset and a very short duration of action, and it can be given as a drip. So dexmedetomidine is not a great induction agent. You're not giving it as a bolus to induce unconsciousness, unlike propofol or etomidate, but it's better for kind of ongoing after somebody's debated or they come out of the bar or something like that. However, if this is used over 24 hours, so if you have somebody on a Sedatives drip for longer than a day, it can rapidly develop tolerance. And that's actually a phenomenon known as tachyphylaxis. Not anaphylaxis, but tachyphylaxis. Tachyphylaxis, and somebody has a rapid decrease in their response to that drug, right? Like, let's say that you are giving somebody albuterol or an asthma attack, and then a couple hours later, they completely quit. The albuterol is completely ineffective. They're spasming, and albuterol just doesn't do anything. That would be tachyphylaxis, right? So somebody essentially, you have rapid development tolerance, and you have a rapid decrease in the effectiveness of that drug. That can happen with Sedatives. The next agent I want to talk about, and this is becoming quite popular in the pre-hospital environment, is something called ketamine, also known as Keltar, and its mechanism of action is very different from the other agents in that it revolves around NMDA receptors. So an NMDA receptor stands for N-methyl diaspartate. And a specific kind of NMDA receptor is a receptor for the neurotransmitter glutamate. And remember, we said that glutamate is the primary excitatory neurotransmitter in the brain. So when you give somebody ketamine, it blocks the glutamate receptors, which are NMDA receptors, all right? And so you cause depression of the central nervous system that way. And essentially what it does is it separates the cerebral cortex from the limbic system. So the top part of the brain, which is the cerebral cortex, cannot communicate back and forth to the lower parts of the brain in the limbic system. It cuts that off. And because it cuts that connection off, chemically speaking, of course, this is referred to as a dissociative anesthetic. And when you dissociate somebody, they may look like they're awake. Their eyes may be open, but they are not conscious. Their consciousness is essentially been separated. And the conscious part of them cannot receive sensory information from outside. It is cut off, if you will. It's kind of like there's a really popular movie called Get Out. And in that movie, there's this concept of the dark place. And when that happens, the guy like everything becomes dark and he like gets ripped away and he's kind of lost by himself while everything else is going on around him, sort of. That is very similar to what we see with dissociation. And this is sometimes referred to as being in a K-hole when somebody gets dissociated, because ketamine is also used not only therapeutically, but it is used in a less than therapeutic context, shall we say. Ketamine also has interesting properties in that at lower doses, it has analgesic properties, right? So it has opioid-like effects at low doses, and then at high doses is where you get the sedation and even induction, right? And this is a really weird one because they appear to be awake. It's like a lights are on, but nobody's home kind of situation. I've seen this a few times. I actually saw it used in Afghanistan. We used it in Afghanistan as well. And there were a couple times where we were having patients help us with surgical procedures. We were performing, what was it? I was doing a big, incision and drainage on a big abscess. And the guy I was doing the I&D on, he was actually helping me. He was holding instruments for me. So he's responding and he could do simple tasks, but he was not conscious, and there was no personality, none of that. It was just a really odd situation. So what are some other things that we see with ketamine? Well, some of the things that ketamine can do is it can cause an increase in salivation. So people can get very wet, right? They can salivate quite a bit. Tends to cause nystagmus. Does anyone know what nystagmus or nystagmus is?
That the bouncing of the eyes when they're tracking eyes and they
Yeah, there you
they
go.
bounce.
Up, they bounce around. Yeah, you see that without ethanol. Yeah. It can cause bronchospasm and apnea if given rapidly. So you tend to either give it a very slow IV push, or you can give it as an IM injection. Tends to preserve respiratory reflexes. So these people can be dissociated, but they tend to breathe and they tend to protect their airway, so they can cough and gag and all that. Really short duration of action, 30 to 45 minutes. And it does cause release of endogenous catecholamines. So if you give it, if your body has catecholamines stored in its neurons, it will release the epinephrine, norepinephrine. So you tend to get an increase in heart rate and blood pressure. So ketamine may be a good agent to use if you have a very shocky patient, someone who's very shocked out, and you're worried about their blood pressure. If they're catecholamine depleted, like a SEP patient, then you won't necessarily see this effect. And then approximately 10% of patients can have something called a reemergence reaction, where as the ketamine's wearing off, they will start having anxiety, hallucinations, and they can have some behavior issues. So it's generally advisable as it's wearing off, you want them in a dark, quiet environment, or you want to give them a benzodiazepine and or give them benzodiazepine to help that out a little bit. Ketamine is actually chemically very similar. It's a cousin to another dissociative anesthetic agent called PCP, phencyclidine, or sometimes referred to as angel dust. And the effects of PCP are, as you might imagine, remarkably similar to ketamine. All right, I'll also talk a little bit about the inhaled or volatile anesthetics. The mechanism by which these inhaled gases work is pretty complicated, and frankly, it's not well understood. Probably involves multiple receptors, to include GABA receptors, and it may even be due to as these molecules pass through the membrane of the neurons, they kind of like push proteins out of the way and they disrupt the membrane a bit. And so that may be part of it as well. We do know the more lipophilic these inhaled anesthetics are, the more lipophilic they are, they tend to have increased potency. So the more lipophilic, the more potent they are, the lower concentration you need to have an effect. That was actually something called the Meyer-Overton hypothesis, when people were first trying to figure out how these things worked. There's a really important concept when it comes to the potency of an inhaled anesthetic, and that's called the MAC. That stands for the minimum alveolar concentration. And that's just the concentration of anesthetic and exhale gas that will cause anesthesia in 50% of the population. All right. And the higher the MAC, the lower the potency, right? And I want to talk about a specific agent because it is used by EMS services and it is in the national curriculum. So even though we use it here next, you do have to know a little bit about it. It's called nitrous oxide, not nitric. Nitric oxide is a radical. Oh, this is N2O nitrous oxide. It's used by some services. It comes in a 50% nitrous and 50% oxygen mixture is a common one. It tends to be self-administered by the patient. It's commonly used in trauma, myocardial infarctions, can even be used in pregnancy. Very rapid onset, very short duration of action, very safe, and the MAC for nitrous oxide is so high that you cannot reliably get to surgical anesthesia at standard temperature and pressure conditions. So at atmospheric pressure, at normal atmospheric pressure, you cannot give somebody enough nitrous oxide to cause surgical anesthesia. So it's very safe. Unfortunately, it can collect in air-filled spaces. And so it is contraindicated in the setting of pneumothorax or pneumoperitoneum. We have abnormal air in your abdominal cavity, or pneumocephaly, air in the in the cranium, bowel obstructions, or decompression sickness, right? Like the bends. Those would all be contraindications for nitrous oxide. All right. There are many other inhaled volatile anesthetics out there, but we don't really use them or directly engage with them. Things like sevoflurane, halothane, isoflurane, and they all have slightly different properties associated with them. But there is, I want to mention, I've mentioned before, and people that receive volatile anesthetics or inhaled anesthetics and other induction agents in the setting of in a surgical setting, in some parents possibly, be at risk from malignant hyperthermia. And I know I've talked about this before in pathophysiology, when I talked about somebody has a sudden, marked increase in their CO2 and their temperature increases rapidly after receiving one of these agents. The primary concern needs to be malignant hyperthermia. And this still kills a small number of people every year. The news is littered with reports of kids in many cases going to have dental procedures and then dying of malignant hyperthermia because this developed. So if you suspect malignant hyperthermia, does anyone remember what the antidote for that is? I talked about how the pathophysiology of malignant hyperthermia is related to a faulty calcium channel in muscles. Do you want to remember the drug that's used? So the drug is actually a special calcium channel blocker. It's called dantrolene. Dantrolene or dantrium. So if somebody develops malignant hyperthermia, you need to rapidly transport that patient to the closest operating room. Hospital that has the closest operating room. The reason being that to have a qualified operating room in the United States, they need to have dantrolene on hand. So you know that there will be dantrolene there. So wherever you're at, you need to divert and rapidly get that patient to the closest hospital that has a functioning operating room so they can get dantrolene. Otherwise, their risk of substantial morbidity, mortality is very high. Malignant hyperthermia is a life-threatening emergency. And just as a reminder, all controlled substances, because many of these substances, right, ketamine, the opioids, the benzodiazepines, right, are, Schedule 2, Schedule 3, in many cases, substances. So they need to be properly secured, and there is special documentation and accountability requirements, right? Typically, you will do a check with the oncoming shift and the offgoing shift. They will be locked in their own box and secured, and there's special documentation. And if you use a partial dose of something and you need to get rid of it, there is there should be a policy for how to get rid of it. Call that wasting. Typically involves 2 individuals signing. So just remember that there's a lot of accountability documentation associated with controlled substances. of which many of these analgesics and sedatives and induction agents belong to the category of controlled substance. All right. So any questions? Any questions so far? All right. Well, the last thing I want to talk about is I want to talk just a little bit about RSI. Does anyone know what RSI is?
Rapid sequence inhibition.
Yeah, it's a very special technique. It's called rapid sequence intubation. And more broadly, RSI belongs to a broad category of interventions that are sometimes referred to as PAI or DAI. That stands for pharmacology assisted intubation or drug assisted intubation or airway management, because there is also something called RSA, rapid sequence airway, that may not involve intubation. But essentially what you're doing is this is a tool where you administer an induction agent you administer something that causes a loss of consciousness, and then you administer a neuromuscular blocking agent we call a paralytic. All right, so you cause a loss of consciousness, you paralyze the patient, and what it does is that in some instances can allow for a safer and more effective intubation. And the reason this was originally developed, or at least RSI, was that most patients in the pre-hospital environment are non-fasted patients. So if you go to the hospital for a outpatient or scheduled or an elective surgical procedure, right, you will have instructions to not eat the day prior to your surgery. So you'll be what we call fasted. You won't have anything in your stomach. We can't make that assumption for people that are having emergencies outside of the hospital. And so the risk for aspiration and other related problems is going to be much higher. And this is one of the techniques that may negate some of the risk of that. And so that's where it originally was developed for. Now, surrounding RSI, there may be what we call pre-medication agents. So you may pre-medicate the patient prior to induction. So you may give the patient some analgesia, right? Like you may pre-medicate them with some fentanyl. And then there are other pre-medication agents as well. But the effectiveness is contentious and debatable, we'll say. But pre-induction analgesia is pretty common. So you give somebody a dose of fentanyl, and then you'll give the induction agent, right? And that typically will include things like ketamine, an induction dose of ketamine, propofol, etomidate, and you might possibly use midazolam or Versed. The problem is you've got to give a really big dose, like something like 0.3 milligrams per kilogram of midazolam. And so you're looking at, 70 kilogram, you're looking at over 20 milligrams of midazolam as an induction agent. And, most of the time, your typical doses of midazolam are, around 2 to 5 milligrams. So you really gotta be bold to give a big dose like that, and then hypotension is going to be a real problem. So technically midazolam could be used as an induction agent, but it's certainly not ideal, whereas ketamine, propofol, and etomidate tend to be very ideal. In some cases, you can even give a large dose of an opioid like fentanyl. You could give a large dose of fentanyl and use it like an induction agent. And sometimes this is done in cardiovascular surgery, where you don't want to cause myocardial depression, depress the heart. And all of these agents, to varying degrees, can depress the heart. Even ketamine can. Most people say, no, ketamine increases cardiac output and all this. Yes, because it causes catecholamine release, and that offsets the, will often offset the myocardial depressing effects of ketamine. Make no mistake, it can still depress the heart. So if you have somebody with a bad heart, something like ketamine, in fact, it's one of the relative contraindications for ketamine is congestive heart failure. I'm glad I mentioned that, because it can cause decompensation of congestive heart failure, where fentanyl may be a safer alternative. So you medicate them, give the induction agent, and then you give a paralytic. And that's just the last class of drugs I want to talk about before we lecture. So paralytics, also known as neuromuscular.
Hey, Chris, sorry to interrupt you.
Yes.
On the
Blockers,
induction agents, can you give a combination to get a desired effect?
Yeah, you could. Typically, we go with a single agent. Now, what happens in the operating room is going to be very different. They're going to be giving lots of different agents, and so they may like give propofol and nitrous oxide for the induction, or they may give propofol and fentanyl for the induction, and then they will follow it up, like sevoflurane to maintain anesthesia. So what happens in the OR is very different, but out in the field, you want, right, because this is rapid. Once you make that decision, right, you want rapid induction of the patient. So you're going to give a large dose rapidly of an induction agent. So typically we use single agents, like a big dose of ketamine, big dose of propofol, or a big dose of etomidate. Yeah, good question though.
Copy, thank you.
No problem. So the paralytics, the neuromuscular blockers, these are agents that block acetylcholine receptors in the neuromuscular junction in your plate. All right. They don't block all acetylcholine receptors, but they target the nicotinic M receptors specifically. And remember, all the way back at autonomic pharmacology, we said that there are different subtypes of nicotinic receptors. So these tend to block the nicotinic receptors in the muscular junction. And so that's their primary mechanism of action. And there are two major categories of neuromuscular blockers. There are what we call the depolarizing neuromuscular blockers and the non-depolarizing. The depolarizing neuromuscular blockers depolarize the neuromuscular junction, so they act like acetylcholine. But what happens is they don't go away. It comes in, it stays attached, it activates the nicotinic receptor. The muscle depolarizes. In fact, you can even get contractions. And so you can get twitching and contractions. And this is called fasciculations, because the muscles are depolarizing and fasciculating. And then what happens is, I don't know, probably a lot of you lift weights, right? And has anyone ever heard of the concept of lift to failure? Is that familiar with anybody?
Yes.
Absolutely.
Yeah. So it's kind of a similar kind of thing going on with a depolarizing neuromuscular blocker. Is it attaches, it acts like acetylcholine. You have constant a continuous signal for depolarization. The muscles fasciculate, and then is essentially what happens is, as you have that sustained, like you're lifting weights and you're lifting, what eventually happens to your muscles? They just fail, just like, I'm done, right? They just quit working on you. And it's something somewhat similar with depolarizing agents. You get a permanent block that occurs, and then the muscle becomes paralyzed, right? So you get fasciculation, and then the muscle just becomes paralyzed. So it depolarizes, it fasciculates, and then it becomes paralyzed. The depolarizing neuromuscular blockers are very short acting, typically within about 30 seconds, and they have a very short duration of action, approximately 5 to 7 minutes. And the only major one that we use in the United States is something called succinylcholine, also known as anectine. And essentially what succinylcholine is it's just two acetylcholine molecules bound together, and there's like a little carbon bridge that holds them together. And so it's just like two molecules of acetylcholine bound together. So it acts a lot like acetylcholine. It just doesn't, its action doesn't stop as quickly as acetylcholine. So it can stay in there for longer than acetylcholine and cause paralysis. So it's good that it's short acting and that its duration of action is short, but there are some side effects. Because it depolarizes, it will increase the potassium. So patients that are at risk for hyperkalemia should not receive succinylcholine. So you think of renal failure, massive burn, crush injury, electrical injuries, those kinds of things. That's a big problem with succinylcholine, is the risk for hyperkalemia. Now, the non-depolarizing neuromuscular blockers act very differently. Instead of activating the nicotinic receptors, they block. So they compete. They actually compete with acetylcholine at the nicotinic receptors. They attach and then they block. They prevent acetylcholine from activating and causing contraction of the muscles. So because they have to compete with acetylcholine, it takes a little longer for them to work. So their onset is delayed. Now we can get around that by giving large doses. We have to give large doses of these, but their duration of action is substantially longer, and it depends on the agent, but you can be looking at 30 minutes to an hour or more depending on the agent. So duration of paralysis is much longer than the depolarizing. And so there are several examples of non-depolarizing. Rocuronium is one of the most commonly used in the pre-hospital environment, also known as Zimron. Vecuronium, also known as, let's see, what is a trade name for Vecuronium? Norcuron. Let's see here. Pancuronium is occasionally used, also known as Pavilon. So those are some examples of non-depolarizing agents. So you can see it's just pros and cons to each, and which one you use really is going to depend on the clinical situation of the patient. And I think that's all we really need to talk about here, because we will not be giving these agents, but you will be in situations where agents are given. So you kind of have to know a little bit about them, and specifically about some of the problems and side effects associated with the use of these agents. All right, it is almost 10:30, which means the second hour is up, and I do want to get you all out of here in a reasonable manner of time. So are there any questions before I let you all go? Any questions? All right. I don't see anything in chat. Well, excellent. Well, thank you all. I know this has been a rough week. There's so much going on, a lot of work to do. We're almost through it. You've got a week off next week, and then just another week and a half of farm left, and we'll be able to get through this. So I will see you all this afternoon in lab. Drive safe if you're commuting, and I'll hopefully see you all soon. Take care.
Thanks, Chris.
Thank you all. You're welcome. All right, let me get this.